In this segment, we will review ultrasound-guided vascular access. This talk will focus primarily on ultrasound-guided peripheral venous access of the upper extremity specifically. However, the techniques demonstrated here also apply to other locations and types of access. After reviewing this lecture, you should be familiar with the two techniques used for ultrasound-guided vascular access and know the pitfalls associated with each. To begin with, since vessels are relatively superficial structures, we select a high-frequency transducer such as the linear array vascular probe shown here. Another option is this hockey stick probe, which has a smaller footprint and therefore can be used on smaller areas or in infants, for example, with small arms. When using ultrasound for venous access, the brightness or 2D mode is used, and you have the option of applying Doppler color flow if needed to distinguish vessels. The first thing to understand is the sonographic appearance of vascular and nerve structures in the area you will be performing cannulation. This is an example of an artery in transverse orientation. Arteries can be distinguished from other structures by their thick, hyperechoic walls, ability to pulsate, and their relative resistance to collapse with pressure compared to veins. Here we see that same vessel in its longitudinal orientation. If there is ever doubt or to confirm the presence of an artery, simply apply color Doppler and you should see pulsating color flow within the lumen of the structure. Veins, by comparison, do not pulsate. They have thinner walls and are quicker to collapse with gentle pressure. Here is a vein in its transverse orientation. Rotating the probe 90 degrees, we can visualize the vein in its longitudinal orientation. It is important to understand the appearance and anatomic location of nerves that may be in the vicinity of the vein you are attempting to cannulate, as it is important to avoid these structures. Here is an example of a nerve in its transverse orientation. Nerves appear hyperechoic and are often described as honeycombed in appearance. Now we will discuss the techniques for performing ultrasound-guided venous access. There are three approaches to this procedure: the transverse approach, the longitudinal approach, and finally a combination of the two. Each approach has its challenges, and clinicians can select which is more preferable for them at the time of the procedure. We will begin by reviewing the transverse approach. First, we must identify a vein in its transverse orientation by placing the probe perpendicular to the forearm. For ultrasound-guided venous access, the indicator can be oriented either to the patient's right or left. However, for consistency throughout the remainder of this talk, when referring to the transverse orientation, the indicator will be pointing toward the patient's right side. Therefore, the patient's right side will be on the left side of the screen, and the patient's left side will be on the right side of the screen. Once we have determined which vessel to access, it is important to decrease the depth to the lowest setting so that the vessel will be better visualized. The probe should be moved until the vessel is midline. With the IV catheter midline, just at the inferior edge of the probe and at a 45-degree angle, penetrate the skin with the needle. Before advancing the needle, it is important to visualize the needle tip on the ultrasound image. Sonographically, the needle will appear in its transverse orientation as a small, round, hyperechoic structure with ring down or reverberation artifact posterior to it. Once you visualize what appears to be the needle tip, you must confirm that what you are seeing on the screen is in fact the tip and not another portion of the needle, since the needle will appear as described when the probe is placed over any part of the catheter. This concept is termed probe slicing and is the biggest pitfall when performing the transverse approach. The cartoon image on the left shows how the probe is imaging along the proximal shaft of the needle and not the tip. However, the cartoon on the right shows the corresponding sonographic image, and if we assume that the structure labeled needle is actually the tip, we might be fooled into thinking that the needle has not yet penetrated into the vessel. In fact, as shown on the image on the left, the needle tip is within the lumen of the vessel. Advancing the needle would only lead to penetration of the posterior wall, which we would want to avoid. In this cartoon, the needle is in the same position under the skin and in the vessel. However, the probe was slid more distally along the length of the needle and is now at the needle tip. You can see from the image on the right that the tip is indeed within the vessel lumen. Therefore, after you visualize what appears to be the needle tip on the screen, slide the probe distally so that you can confirm that what you are seeing on the screen is actually the needle tip and not a more proximal portion of the needle. Once this is confirmed, the needle can penetrate further through the tissues, or vessel if you have already penetrated the anterior vessel wall, but only a very small distance. Then you should again slide the probe distally until you can visualize the tip again. The needle is advanced a short distance again, and the probe slides distally. This back and forth of the needle advancing and then the probe sliding continues until the entire catheter has advanced through the skin, or you are confident that enough of the catheter has cannulated the vessel. There are different thoughts on how much of the procedure should be under direct ultrasound visualization. We will now review the longitudinal approach to ultrasound-guided vascular access. We begin by first visualizing the vessel again in its transverse orientation. By carefully rotating the probe 90 degrees over the vessel, you will be able to visualize the vein in its longitudinal orientation. As with the transverse approach, the indicator can be pointing to either end of the patient, and for consistency in this talk, the indicator is pointing toward the patient's head. Therefore, the patient's head, or proximal, will be on the left side of the screen, and the patient's feet, or distal, will be on the right side of the screen. With the needle placed just at the edge of the probe, penetrate the skin and you should be able to visualize the needle in its longitudinal orientation. You can see how this approach confers the advantage of visualizing the entire length of the catheter and therefore minimizes the risk of posterior wall penetration. The biggest challenge to this approach is the very narrow ultrasound beam under which the needle will have to be precisely placed in order to visualize it on the screen. Therefore, it is not uncommon for the footprint of the probe to overlie the needle. However, if the needle is not lined up precisely with the ultrasound beam, you will not visualize the needle on the screen. Some advocate integrating both the transverse and longitudinal approaches in order to attempt to avoid the pitfalls of both. In this case, we would begin the procedure in the transverse orientation, and once the needle tip is visualized, the probe is rotated 90 degrees and the remainder of the procedure is done using the longitudinal approach. Briefly, we will touch on central venous access and begin with femoral venous cannulation. Anatomically, the femoral vein lies medial to the artery in the femoral triangle. Here you see the femoral vein being accessed through a transverse approach and the corresponding sonographic image. The indicator is pointing toward the patient's right, and therefore the patient's right side or lateral is on the left side of the screen, and the patient's left or medial is on the right side of the screen. The internal jugular vein is the other central vein commonly accessed in the emergency setting. Compared with the femoral vein, the internal jugular vein lies lateral to the carotid artery. Since the internal jugular is accessed with the operator facing the patient's feet, it is important to note which direction the indicator is pointing and the corresponding sonographic image. Here you see the internal jugular vein being cannulated through a transverse approach. Medial is on the left side of the screen and lateral on the right. As a reminder, a common pitfall with the transverse approach is not visualizing the needle tip and consequently penetrating the posterior wall. In the longitudinal orientation, the challenge is aligning the catheter precisely along the midline of the transducer.